Hi, and welcome back to Pharma Simple. In this video, I'll be going through the patient query portion of our cardiovascular case study themed around hypertension and atrial fibrillation. Now, if you haven't already watched part 1 of this cardiovascular case study, I would strongly suggest you do so to help get you a backdrop on our patient, as well as get up to speed on some of the relevant pharmacology and pathophysiology I discussed during that video, which may apply here. I've left a link for that video in the description below. Now, first of all, I'm going to do a very brief recap of what occurred during part 1 of our cardiovascular case study, just to get you reacquainted with what happened. So the question I presented in part 1 read as follows. A regular patient of yours, 76-year-old Miss A. Pulse, enters the pharmacy after recently returning from a trip to our home country of Nigeria. Miss Pulse says she needs to pick up some new medication for high blood pressure along with something new for her heart. Miss Pulse said she went to see her GP because recently she felt her heart has been beating really fast and that the doctor has diagnosed her with a funny sounding condition called AF. She presents you with the following prescription. Now, after analysing the prescription along with the details provided by Miss Pulse, we discovered our first drug therapy problem. Miss Pulse had been inappropriately prescribed an ACE inhibitor, ramipril in this case, for her high blood pressure. It would have been more suitable due to her ethnicity to give a different antihypertensive, for instance a class of calcium channel blockers known as dihydropyridines. Now, putting the pieces together that the bisoprolol had been prescribed for atrial fibrillation, also known as AF, we came to our second drug therapy problem. Miss Pulse had not been prescribed an anticoagulant, which is especially important as Miss Pulse is at a high risk of a stroke. Now that we are up to speed, this brings us to our next question involving our patient query. Question 2. After referring Miss Pulse to the doctor flagging your concerns with her prescription, Miss Pulse returns to the pharmacy a few days later. She comes in to thank you, saying the doctor had put her on a blood thinner based on your recommendation and had decided to change her ramipril to a medication called amlodipine. Miss Pulse explained she had come in to buy some ibuprofen for a headache that had just started this morning. What would be the most appropriate advice to give Miss Pulse? Based on the last video, we know that amlodipine is a commonly prescribed dihydropyridine. Now, it is well established that dihydropyridines commonly cause headaches, flushing and edema due to their rapid peripheral or vasodilatory effect. This may also cause reflex activation of the sympathetic nervous system via baroreceptors and commonly in the carotid sinus and aortic arch of the heart, which detect changes in tension of the arterial wall. Thus, a drop in blood pressure may trigger the sympathetic nervous system as a homeostatic mechanism to increase the heart rate to help elevate the blood pressure back up, leading to side effects such as tachycardia and palpitations. Therefore, based on the knowledge we have just picked up, it is possible that Miss Pulse is suffering a headache as a result of initiating a calcium channel blocker. Inform Miss Pulse that her headache is most likely due to the rapid widening of blood vessels caused by her amlodipine, but that the side effect tends to reduce in prominence over time. If not, she can return to the prescriber to look at other options such as a reduced dose, longer acting preparation or a different medication altogether. In the meantime, a painkiller can be used temporarily. However, ibuprofen may actually worsen Miss Pulse's blood pressure and increase the risk of cardiovascular events through different mechanisms, as well as worsen kidney functions, sometimes even potentiating renal impairment, which is especially important in elderly patients as their renal function tends to be lower. Note that this may affect the dose of drugs cleared by the kidneys as well. Normally, prostaglandins dilate afferent arterioles branching from the renal artery, increasing blood flow to the kidney, and thus filtration of blood by the glomerulus. By inhibiting prostaglandin production, this causes vasoconstriction of the afferent arterioles, reducing blood flow to the kidney, and thus the glomerulus filtration rate, also known as GFR. Remember, GFR is directly related to kidney function, so by decreasing the GFR, the kidney function worsens. Multiple mechanisms are thought to contribute to why NSAIDs may increase the risk of cardiovascular events. Prostaglandins enhance sodium water excretion. Thus, by NSAIDs inhibiting prostaglandin production, this increases total blood volume, which increases venous return to the heart, increasing cardiac output, the total volume of blood pumped out of the heart each minute, in turn increasing blood pressure, which may increase the risk of a cardiovascular event. Endothelial dysfunction and oxidative stress are also thought to play a part in increasing the risk of a cardiovascular event such as a heart attack or stroke. Note the cardiovascular risk increases even in the short term, beginning within a few weeks of starting to take an NSAID in some cases. Different NSAIDs may carry more or less of a cardiovascular risk than others. In the case of a standard dose ibuprofen, the risk is low. Nonetheless, there is no need for any unnecessary risks, and even so, she needs to be monitored by her practitioner. As a result, it is better to offer Miss Pulse a safe alternative such as paracetamol. That concludes part 2 of our cardiovascular case study for this week, bringing cardiovascular case study number 1 to a close. For more resources and enrolling in one of our in-depth teaching courses, please visit our website on www.pharmasimple.co.uk. If you enjoyed this video, please hit the like button, share this video, and don't forget to subscribe.